The first topic that we'll go through for the GI pathologies are oral cavity disorders. So, this is at the very beginning of the alimentary canal, and it's the mouth's job, remember, to chew and to aid in swallowing. So, we'll start out with one of the most common inborn errors. So, this is a cleft lip and or cleft palate. And the lip and palate are made out of different tissue types, with your lips being made out of a much softer epithelial tissue than the hard palates at the top of the mouth. But all of these things emerge from cell masses which are destined to become the various facial structures. So everything needs to fuse properly so that these two masses of tissue will grow medially, which means towards the middle, and eventually fuse at the midline to form a nose and mouth. In this disorder, we see maldevelopment of these two masses of tissue fusing together in about 1 in 1,000 births, and it's a pretty complicated multifactorial inheritance pattern. So it's not something easily predicted. It can be something seen in a sonogram, so it can be prepared for, so that surgical needs can be set up, and then a plan for feeding and things of that nature can be set too. Because of the soft tissues involved in cleft lip, this can be corrected very soon after birth. But because of the nature of the tissues making up the hard palates, a cleft palate won't be surgically corrected until 1 to 2 years after birth. And then they will work with a speech pathologist, which not only will help them to acquire speech patterns, but also aid in swallowing and other things we kind of take for granted with regards to the mouth. So here is a drawing from a textbook going through these various abnormalities of the palate. So in A, we see what you're looking at are in pink the lips, the nose is on the top, and then we have the palate. This would be the top of your mouth here. So everything fuses towards the midline. So this first picture in A is showing a one-sided or unilateral cleft lip. So this didn't close medially. And B, we see a bilateral cleft lip. So there's improper fusing here. Then in C, we start to see bilateral cleft lip and then a cleft palate. In D, we have a cleft palate, but normal lip tissue development. In E, there is a cleft palate, unilateral cleft lip, and then in F, we have cleft palate and bilateral cleft lip. And we'll see what these look like in patients. So these are going through some of the ones we just looked at. So in A, this is a unilateral cleft lip. So these two sides just didn't fuse together in the center. So it just leaves this open cleft. In B, we see unilateral cleft lip, and we can also see the starting of a cleft palate back there. Do we see that? So now we have a cleft palate and then a full bifurcation of the lip. So unilateral cleft lip. And then in D, we have unilateral cleft lip and a cleft palate. So I want you to notice that when you're looking at these cleft palates and cleft lips, it's going to present some problems with feeding. When you look at cleft palates like this, they actually do sell special nipple tops for bottles with babies born with cleft palates because the bottle has to extend past this open cleft area before this can be eventually corrected surgically. So here is an infant that was born with bilateral cleft lip and a full cleft palate. And when those things co-occur together, you do see the protrusion of the tissue that's kind of left out. So this protrusion of tissue between these clefts. These look like teeth here. Those are sometimes called milk teeth, but we'll refer to them as deciduous teeth. So the teeth that will grow into the head essentially pretty soon after birth. So these are buds of teeth. They're not fully formed teeth. There are cases of babies being born with fully formed teeth. That's only about 1 in 5,000. I used to have nightmares about that and waking up and seeing a baby with a full set of teeth being like, hi, mom. But it's okay. that is something that can be surgically corrected. Um, in this case, this is what this looks like upon birth, and then this child is after the same kid, 18 months after surgical correction. So we see that this is a surgery that is very, very successful in closing the lift and the palate. So these, again, these are just multifactorial inherited patterns of cleft lips and cleft palates, and they can be surgically corrected as long as there is access to medical care. Then there's abnormalities of tooth development. So this would be with a cleft lip or palate. These are just talking about teeth. So this is looking at the two sets of teeth. Here's the deciduous teeth or the milk teeth. There's 20 of them. They start to fill in a couple months old, and they usually are all in by the age of 2 years. Then later on, around the age of 7 or so, those deciduous teeth start to fall out, and then the permanent teeth start to come in. There are 32 permanent teeth that we plan for. It's a really common abnormality to have a missing tooth or an extra tooth or possibly multiple teeth. And then we'll see a discoloration that occurs when there is administration of antibiotics called tetracycline to very young children, or more commonly to pregnant women, because tetracycline does incorporate with the calcium structures in the bone, which leads to permanent discoloration. The bone that you can see all of the time are the teeth. So those are the most obvious that are discolored. So here we're looking at a pretty cool, like almost like a Punnett square of genetics with missing teeth. So this is a mother, and next to the two front teeth, there should be two incisors, and then it gets into the sharper canines. So what you see here, the normal teeth production on one side, then we have a big tooth, and then we have a canine next to it. So they're missing this little incisor. So when there was an offspring, here's the daughter now, she has the two big teeth, and now she's missing both of the incisors. So it'd be a fun little genetic experiment to do a Punnett square and figure out, as we go down the genetic line, what teeth will look like in the offspring of this daughter. So this is a really common abnormality. This would not affect somebody's life really whatsoever. You can see that it looks as though their teeth are normal. You have to look really close, and they will have absolutely normal activity with chewing and speech and all of those things. And this is what tetracycline staining looks like. Again, tetracycline is an antibiotic, and it does incorporate itself into calcium, and calcium is a part of bone. Most bone you cannot see, but the bone in your teeth you can. So this is a permanent discoloration, so it is recommended that tetracycline not be given to very young children or to pregnant women to prevent this permanent tetracycline discoloration. Okay, and then we have periodontal disease, which means around the mouth, around the teeth disease. So you probably know you're supposed to brush your teeth every day, and that's good for you. But what's even more important is flossing, because throughout the day, you've got saliva, you've got all this stuff going on in your mouth, and the saliva and the bacteria and broken down food, it forms this, what we call plaque on the surface of the teeth. And eventually plaque leads to what's called caries, which is Latin for rot. And so caries is essentially a biofilm of plaque and saliva and food products that builds up on the teeth and forms little calculi, which are little like crystals, like calcium crystals. And they start to deposit themselves underneath the gums. And the more calculi there are, the more inflammation and swelling there is. So where you see here, plaque plus bacterial action equals tooth decay, the caries. So the bacteria that we are protecting against by flossing are anaerobic bacteria. That means they thrive in places where there's no oxygen. So if you look at these healthy gums down here, when you floss, what you do essentially is introduce air pockets between, so I'll just draw one right here. So see how close together these teeth are? You floss, and now you have an air pocket there, which means any bacteria that were chilling out between these two teeth, now they're dead because they can't live in oxygen. So flossing, even when you're really tired and you don't want to do it, just picture the millions and millions of anaerobic bacteria hanging out between your teeth, making the human mouth really disgusting. So when people floss, there is no bacteria that's left over. If there is no flossing, then those calculi plus bacteria, they build up, they go underneath the gums, and you start to see redness and inflammation. So if you poked this person's gums, they should have a normal capillary refill, and it should look just like blanching the skin on your forearm. Here you'll see abnormally slow capillary refill. Do you also see how the skin has started to grow between those because there's so little flossing here? So this is all skin now that we don't want to be there. And there's bacteria living under there with these calculus crystals. So you get gum inflammation, and that's called gingivitis because the gums are the gingiva, so inflammation of the gums. The way that the dentist knows if you're lying or not about flossing is if somebody who flosses every day, so this person, if they went to the dentist and they put some floss in between their teeth, they wouldn't bleed. When there is bleeding from the gums, so here, if they went to the dentist and there's a lot of blood coming from where the floss just went, that indicates that there's not flossing going on. And eventually, gingivitis turns to periodontitis, where, do you see this here, though, the gray stuff? That's the calculi. So that's that caries. That's your mix of plaque, of anaerobic bacteria forming these little crystals, which deposit themselves underneath the gums. You also see the teeth starting to recede, or the gums starting to recede. So here we have, this is the base of the teeth, and this is the surface of the teeth. Here, drawing the same line, the gums start to recede more and more and more, so that eventually when you get to these later stages, do you see how much the gums have receded here? So the gums start to recede away, huge amounts of calculi and caries, pockets of infection between the teeth. And now this is really difficult to get rid of. It has to be drilled out. It has to be cleared. And because of all the bacteria that live here, this is associated with lots of infections to the kidneys, to the lungs, to the heart. So tooth health is really important. It all comes down to just flossing. Floss. Flossing kills those anaerobic bacteria by introducing oxygen to these teeth pockets. That's why people use things like peroxide mouthwashes and peroxide toothpaste. Peroxide fizzes up and it makes oxygen appear in places where it wouldn't be normally. Other things that can go wrong. Inflammation of the mouth is called stomatitis. Stoma is mouth, inflammation, itis. So inflammation of the mouth, here are the bottom of the teeth, here is the lip, and here we see a little sore, we see redness, swelling, there's exudate. People call these like canker sores, and these can pop up for a variety of reasons. They can pop up because when stress goes high, the immune system goes low, so you can have an overgrowth of different bacterium. Fungi like Candida albicans is a yeast type of product. The herpes virus causes sores here, but also just irritants like alcohol, tobacco, hot, spicy foods. They can cause mechanical damage and then irritation. If you've ever had a really hot beverage you weren't expecting, you get a little cut in your mouth or on your tongue from that, and it gets inflamed, and that's essentially stomatitis. And if that person reverses their behavior or reduces their behavior, hopefully this doesn't progress to something worse. So this is still reversible at this time. What is not reversible is oral carcinoma. So here is carcinoma of the oral cavity. And when people go to the dentist, they say they're doing a mouth cancer screening, which essentially just means they're looking at the inside of the mouth to make sure there's nothing abnormal growing in there. We can tell that this is a carcinoma. Remember, carcinomas involve connective tissue or like epithelial tissue. The lining of lumens is squamous epithelium. So this is a squamous cell carcinoma. And remember from the cancer chapters that when you look at these malignant tumors, these carcinomas of tissues, they don't look like the rest of the tissue. So here we have normal gum tissue, and here we have the carcinogenic tissue. So in this case, this would have to usually result in some sort of surgery to remove this offensive tumor. So this can happen anywhere in the GI tract, oral cavity, so lips, cheek, tongue, the palate, the back of the throat. So it's just carcinoma of the oral cavity, but people use the term mouth cancer or head and neck cancer. Okay, so that's everything that could go wrong in the oral cavity for now.